One more minute before we get started to allow some people to come in to the meeting. We have about 25 registered. Okay, I'm going to go ahead and get started. We might have some people popping in a little late. My name is Caroline Johnson, and I'm the founder and executive director of Twisted Pink, and we are a nonprofit organization headquartered in Louisville, Kentucky. Our mission is to provide hope and connection to people living with metastatic breast cancer, and we do that by funding bold breakthroughs in research and awareness of the disease. We also send boxes of hope across the country to people that have been diagnosed with breast cancer, and that's been a program that we started at the beginning of COVID as a way to reach out to patients, and we provide gifts of comfort and joy, as well as educational materials about breast cancer and our organization and what we do. And recently we connected with JScreen Genetic Testing, which is another nonprofit organization. And Emily Goldberg is going to tell you a little bit about their organization and talk to us about genetic testing before and after diagnosis today. So Emily is our speaker, and she is a genetic counselor. She has her bachelor's degree in biology and psychology from Brandeis University. She also has a master's degree in genetics from Sarah Lawrence College, and she's been certified since 2011. She's been working in genetics with fertility and cancer, and I am going to turn it over to Emily to talk to us today about genetics. And just so you all know, if you have questions, we would prefer that you put them in the chat. So at the bottom of your screen, you should have a little chat button, and you can put questions in there, and we're going to save all of those questions for the end. If you are not able to connect to the chat, you can use the little raise your hand button or just flag me with your hand, and I'll allow you to ask questions verbally at the end of the presentation. And so we're glad everyone's here today, and I'll turn it over to Emily.
Hi, everyone. And Caroline, thank you for introducing me and including me today. And basically what I want to do is just give everybody a little bit of information about what genetic testing is and how it can be useful, both for somebody who has cancer, for somebody who doesn't have cancer, and for their family members. And there's a lot of misconceptions and misinformation around genetic testing. So I'm going to give you a little bit of a lesson. And then we also have some sponsored testing. So for anybody who is watching that has not had genetic testing at this point, but is interested, or you have family members or other people within your network who are interested in testing, I'll go through a little bit at the end about how to do that. But again, we do have some sponsored testing, which will allow people to come through at no cost. So I will definitely go through that. As Caroline said, definitely feel free to put your questions in the chat, and I will try to get through all of them. But just to give you a little bit of a background lesson. So you hear some of these genes like BRCA1 and BRCA2 get thrown around a lot. But just so that you're aware, everybody has these genes. So BRCA1 and BRCA2 and a whole host of other genes. Everybody has them. And when they're working normally, they're there to protect us from cancer. So if you think about them as security guards, they're on the lookout for our cells making mistakes and acting up, and they try to fix it before it becomes a problem. So it's this sort of natural protection that everybody's born with. Now, if there's a change in a gene and it makes it not work right, then that gene can't do what it's supposed to. So we're more susceptible to certain types of cancer, which means that the risks in our lifetime are higher depending on what gene is impacted and or not working. So just as an example, because more people are familiar with a gene like BRCA1, anybody with or without a genetic predisposition can develop cancer in their lifetime. But we know that certain genetic changes are associated with dramatically higher risks. So, for example, people who have a BRCA1 genetic change have up to an 85% lifetime risk for breast cancer. And we can see it occur at a younger age than usual, right? So most people with breast cancer are not in their 20s, 30s, and 40s. But with BRCA1, we can see it occur at those younger ages. We also see that there's a higher risk for ovarian cancer, which can be about 40 to 60%. And then other risks that are not quite as high, but still important for prostate cancer, pancreatic cancer, and male breast cancer. So the idea behind doing genetic testing is to sort of learn about these risks, know what it is that you're up against, and to use that information to benefit both cancer prevention and screening and informed treatments. Now, even though I've kind of highlighted BRCA1, it is not the only gene that's associated with cancer risk. So this is just a list of some of them, but there are even more than that. And just kind of goes to show that there's a lot of genes in our body that protect from cancer or can contribute to our risk. And they may have different types of cancer associated. Like some are associated with breast and ovarian cancer. Some may include colon cancer or uterine cancer or kidney cancer. So even beyond just breast cancer, though that's what we're certainly focusing on today, there are other types of cancer that can have a hereditary component. And we can see those occur within families as well. So one of the most common questions is, okay, so we do genetic testing and we find that somebody has a genetic predisposition. What's the point? What do we do with this information and why is it helpful? One of the big things is because it can inform cancer screening and risk reduction. So for example, we may recommend that somebody does extra breast cancer screening, like adding in breast MRIs in addition to routine mammograms. Or if somebody has an elevated risk for ovarian cancer, we unfortunately don't have great screening for ovarian cancer. So we do recommend that women have their ovaries removed preventively, because otherwise we tend to find them at more advanced stages. And so depending on the genetic change that somebody carries, we can make recommendations about some of these that you're seeing here and more. So changing their colonoscopy schedule or starting at a younger age, or different blood or urine tests to screen for cancer and either prevent it or detect it at an earlier, more treatable stage. Now, many people associated with Twisted Pink say, I already have cancer, so how is genetic testing useful, or how can I use this information? And there are a few ways. One is surgical decisions. So if somebody is diagnosed with breast cancer at a time when they are at the beginning of their diagnosis and they're trying to figure out what type of surgery do they want, genetic testing can play a part. So for example, if somebody's positive for a BRCA1 or BRCA2 mutation, they may consider, instead of lumpectomy, if that was an option, consider a mastectomy or even a bilateral mastectomy to also lower their risks for a future diagnosis. And by knowing this information going into surgery, that can help make sure that you have all those different bits of information that can inform what's going to be the right decision for now and in the future. There are also targeted therapies that are available to people that carry certain genetic changes or not carry them. So one example is PARP inhibitors. And this is a particular class of medications that's designed to target cancers that are caused by BRCA-related genetic changes. And they work really well for people whose cancers are caused by those changes and really don't work well for people that don't carry these mutations. So by knowing somebody's genetic status, you can really make specific decisions about, is this medication going to work for me? Is it not likely going to work? And to avoid wasting time trying different medications, we can be much more specific by looking to see, here's my genetic information, and let's specifically target that particular cancer based on everything that we know. Now, as I kind of showed before with some of the risks associated with BRCA1, even if somebody has cancer now or they've had it in the past, some of these genetic changes are associated with more than one type of cancer. So even if somebody already has a diagnosis of breast cancer, we may still learn about risks for ovarian cancer or colon cancer or uterine cancer. And by doing this genetic testing and knowing what else may be concerning, we can take steps to reduce those risks for the future. And I don't want to reduce the feeling that some people can have from finally getting an answer. But so for a lot of these families, we've seen cancer affect multiple generations and multiple women and men in the family. And you may be wondering, why has cancer ravaged all these generations of family members? And so sometimes genetic testing can be a relief where we can say, you know what, we finally pinpointed the exact cause for a lot of this cancer in the family. We know now why it's happening. And that can be really emotional. It also means that because we have found that answer, we can then turn that around and use it to help both cancer treatments, as I said, screening, prevention, family planning, testing for other family members. And speaking of other family members, genetic testing is sort of a unique field of medicine where when we're taking care of you, we're taking care of you, but also your biological relatives. And that's because we share a lot of this genetic information. We get half of our genes from the egg, we get half from the sperm. If we have siblings, we share about 50% of our genes with them. If we have children, we pass on half of our genes to them, and the other half comes from the other side of the family. So it's really a family affair, and this information can provide a lot of insight into medical management for other people as well. In most cases, though there are exceptions, most of these conditions are passed on in what we call autosomal dominant. So what that means is we have 2 copies of every gene. Again, one from egg, one from sperm. And when we go to have children, we pass on 1 copy of everything, and then the other biological parent is passing on the other half. So for somebody, for example, who is BRCA2 positive, they have 2 copies of that gene, and they pass on either the one that's completely normal or that one that has that genetic change in it. So for their children, they each have a 50-50 chance to inherit that same genetic change. And it's like heads or tails flipping a coin. We can't control the genes that we pass on, but it does allow us to have that information to know that our children are also at risk. And when they're at an age when they can start to act on this information, they can consider testing for themselves as well and seek out any screening or preventive measures that would be recommended. And then for those families that also carry that particular genetic change, they can make their own plan with their doctors about what kind of next steps to do. Now, at a time when, if somebody finds out that they carry a genetic change at a time when they're planning their family, so planning to have children or add additional children to the family, this information can be useful for a few reasons. One is to know what the options are for their children or future children. One is people have children. When they're grown, they recommend this testing. And they can be tested as an adult, just like they were, and start with the screening and preventive measures that are recommended. Another option is a patient can go through what's called in vitro fertilization, which you may be familiar with. It's essentially a fertility treatment where we get eggs and sperm and combine them in the lab to create embryos. And usually those embryos are then transferred to the uterus, hopefully resulting in pregnancy. Most people who are seeking IVF are doing it for reasons of infertility, but there's an extra level of testing that can be done on these embryos where you biopsy each embryo and do genetic testing for the particular genetic change or genetic condition that you're concerned about, and specifically choose embryos that are found to be unaffected. So it's a way of tipping those scales and taking that 50% and turning it into avoiding passing on those genetic changes. People can also consider gamete donation, which is like egg or sperm donors who are found not to carry that particular genetic change, or choosing to adopt or not have biological children. Now, there are some conditions that we screen for. So for example, with BRCA2, if I meet a person who is BRCA2 positive and they're planning to have children, I actually recommend that their reproductive partner also do testing for BRCA2. And that's because aside from the cancer risks that are associated, if two parents are both positive for BRCA2 and a child that inherits two mutations, one from each parent, then they can actually be at risk of developing a different condition, something called Fanconi anemia. And this can cause childhood cancer risks, immune system disorders, and physical birth defects. So the only way to know ahead of time if somebody would be at risk of having a child with Fanconi anemia is to make sure that both parents are tested. So BRCA2 is an example. There are other genes that we test for, such as ATM, that can have these, what we call recessive risks, meaning they have to come from both parents. So one of the most common questions that I get is, for my children, when should they consider genetic testing? And part of that is when they're ready to hear that information and learn their genetic status, which can be a different age for everybody. Another is when they're planning their families, so they can test their partners or consider fertility treatments. And another is based on the gene. At what age do they need to start screening? For some of these genetic conditions, like Li-Fraumeni syndrome, we test babies because there are childhood cancer risks. For most of them, we wait until adulthood because it's not associated with any cancer in childhood, but it depends a little bit on what age screening would begin. So I want to kind of go through some of these common misconceptions. We've already touched on the top one, which is I don't need genetic testing if I've already had cancer or have it currently. And we've gone through some of those reasons why it could still be impactful. Another one is for men in the family, that men can't get breast cancer or that they don't need genetic testing. So first of all, men can get breast cancer. It's less common than for women, of course, but it is a risk. And some of these genetic changes can actually put men at a much higher risk than the general population. So it's important for them to be aware of their risks and to get any symptoms checked out. We can also, men and women are just as likely to carry these genetic changes. So they can come from either side of the family. So when you're gathering information about your family history, or your doctor's asking, is there anyone in the family that's had breast or ovarian or colon cancer, to not forget about the paternal side, because that genetic information is just as important. And that some of these genetic changes are associated with risks for men as well, like prostate cancer. Things like colon cancer or pancreatic cancer can affect both men and women. So we tend to stick to thinking about breast and ovarian cancer, which obviously affects women more, but not to forget about the men because it can also change their risks and their recommended screening. And they can also pass it on. So if you say, well, I have only sons, but their sons could have daughters as well. So to kind of pay attention to the whole family. Another one is that, I'm the only person in my family who's had cancer, or I've never heard of anyone in the family having cancer. So it can't be something genetic, or I don't need testing. And we often find that that's not true. So there could be a lot of men in the family. And since those risks, let's say for breast cancer, are much lower, maybe it just hasn't come up before, even though the genetic changes are there. Or somebody has a really small family, or they're estranged from their family members, or they're adopted, so they're, missing a lot of that information. Anybody can carry a genetic change, and sometimes the only way we're going to know that is to do the genetic testing. So even if you've had cancer and there's nobody else in your family, you don't know of any cousins, it still could be genetic, even without additional history. And then finally, there may be a lot of people who have had BRCA testing in the past, and let's say it was negative, and they say, okay, well, my breast cancer is not genetic. I don't need to worry about it. I'm done with genetic testing for life. Now, while it's true, our genes never change over time. We're born with them. So once we have them, they grow with us. We have them forever. However, what does change is the testing and the technology and what we know about cancer and genetics. So it used to be that we could only test for BRCA1 and 2. And then over the last 15, 10, 5 years, there's so much more that we've learned, and there's so much more that's available for testing. So if you had BRCA testing in the past and it was just limited to those 2 genes, it may be worth circling back and updating the testing to see if you carry a genetic change that wasn't tested for at the time, but could now identify a specific reason for the breast cancer. And again, inform decisions about other types of cancer risks, and also give you that information to share with family members. These panels update every couple years. So I always recommend that people stay in touch with their doctors and their genetic counselors if there's any new information that could benefit the family. Now, if you're ready for testing, either you've had it in the past and you're thinking about an update, or you've never had it before, but you're thinking about it, or you're starting to think about those friends and family who may benefit from it, there are different ways to make this happen. I do always recommend doing genetic testing in the setting of somebody who's very experienced with this type of testing. That can be oftentimes a genetic counselor like myself, though oftentimes, a breast surgeon or an oncologist may also have a lot of experience ordering these types of tests. But just to make sure that you're in good hands with somebody who can order the right test for you and interpret it properly. For anyone who's interested in going through JScreen, I'm going to give you a little bit of information about how our process works. But as Caroline said, we're a nonprofit. We're based out of Emory University in Atlanta, though we are a national program, which basically means that anybody can do testing from home for an entire cancer genetics panel. So our current panel is 63 total genes. It includes all the genes that we currently know about being related to breast cancer, certainly BRCA1 and 2, but other ones such as ATM, PALB2, CHEK2. So it's quite a list of conditions, and it covers other types of cancer as well, aside from just breast. So people can go to our website, which is jscreen.org, and we have some videos and information, but there's a button that says request a kit. We do work with your doctors. So we ask for your doctor and your insurance information, and we reach out to your doctor's office to have them get a test order. That way, when everything's done, we have somebody to send it back to for your ongoing care. And we send you out a tube that you spit into from home. You fill it up with saliva, you drop it back in your mailbox, and then a couple of weeks go by, and the results are ready. And a genetic counselor will reach out to offer you an appointment to go through those genetic testing results and make any recommendations based on what we find. And then, as I said, we send that all back to your doctor's office so that way they can continue with your ongoing care and use that information to make decisions. And you can also use that information to share with your family members. Typically, there's a program fee that we charge for testing. But as I said in the beginning, we are offering Twisted Pink sponsored testing. For anybody watching, for anybody who is watching the recording, or as I said, if you have people in mind, like your family members or your friends who have yet to be tested, but you think would be interested or benefit from it, if you go through the registration and at the end you put in this code that's KICKPINK, it will make the testing no cost. Okay? So as long as we do still ask for insurance information. We're a nonprofit. We like to keep our costs low when we can. So the lab may bill the insurance for the testing, but regardless of any benefits or whether or not it's covered, it's $0 out of pocket for anybody who's using this code. And it's going to be available through the end of April. So it gives you a little bit of time to think about it. to speak with family members or talk to them about it, or for people who haven't had a chance yet to watch the recording, gives you a little bit of time to do so. So definitely feel free to take advantage of that. This is thanks to another nonprofit that we work closely with called KICK, which is Knowledge is Cancer's Kryptonite, started by two sisters who are BRCA1 positive themselves, and they raise money to be able to fund genetic testing for people who need it. So sort of the combination of KICK and JScreen, definitely feel free to either reach out with questions, learn more on our website, or consider genetic testing if you've never done it before. I think what I want to do is I'm going to unshare my screen so that way I can see you. And then if anybody has any questions, to definitely feel free to throw those in the chat. I'm happy to answer any kind of questions if you have them.
So I'm going to start with a question. It might give other people an opportunity to think of other questions as well, because I don't see any in the chat yet. But when you have a genetic mutation, is that always something you're born with, or can you develop those throughout your life?
So good question. The type of genetic changes that I'm talking about that sort of give people these lifetime increased risks, we are born with.
Okay.
These are ones that we inherited from our mother or father. Occasionally, they can be brand new in that egg or sperm, and we can have them even if our parents don't. But they're genetic changes that we're born with, so they're in every cell of our body. Now, there are other genetic tests out there that people may have had, something called somatic testing, where sometimes they do genetic testing on somebody's actual tumor to figure out what genetic forces are driving it. And those genetic changes are unique to that particular cancer cell and not ones that we're born with. So those are different types of genetic testing that can also help inform treatment. But these types are ones that we're born with.
Okay. Does anyone else have any questions for Emily?
I have a question. I have two, and I'll take turns with someone else.
Perfect.
So, hi, my name is Janice, and I'm a 3-year breast cancer survivor with triple negative was my breast cancer, which is common in African American women. My mom had breast cancer before me 20 years ago, but it was a different type of breast cancer. I was tested for genetic disposition, and it came out negative, meaning I'm not disposed or my children's not disposed. So the two questions are, should my daughter, well, let me ask you this other question. You said that your genetics is built up 50-50. Is it really evenly 50-50 from the mother and the father?
Yes.
Okay.
And that's because you have 2 copies of each gene. One came from the egg, one came from the sperm.
Okay. So my daughter, Jamie, she's going to get tested, but her likelihood is not at risk because of me, because of it came out negative. Is that correct?
So yes, as long as the testing that you had was fairly recent and it was for a panel of genes. So if you were only tested for BRCA1 and BRCA2, then for you, I'd recommend updating your testing. If you were tested for all these genes that I'd recommend and you were negative, then you're right. Your daughter is not going to inherit something from you that you don't carry. Now, since half of her genes come from her dad's side, if there's any history on his side, or again, sometimes even if there isn't, she has a possibility that she could have inherited something from him. If her test is out completely normal, we can't tell her that she's at a low risk for breast cancer, because with both you and your mom having it, and you look pretty young to me, her risk is still going to be higher than the general population because she has a mom and a grandmother who have had breast cancer. So she may still need things like breast MRIs. She may still need to start her breast cancer screening at younger than 40, depending on how old you were diagnosed.
Okay.
So it can still even if your genetic testing was negative, it doesn't mean she's totally off the hook. But again, I would make sure that your testing was for more than just BRCA1 and 2.
Okay, I'll check that. Thank you so much.
You're welcome. Do you want to just throw in part 2?
Those are the two.
Oh, those were
whether
the two. Okay.
50-50.
All right. Perfect.
So we do have a question in the chat. So Mona is asking, what other genes do you look for other than BRCA1 and 2 that contribute to cancer? And also, do any other genes contribute to poor response or poor prognosis?
So yes, aside from BRCA1 and 2, there are about 20 to 30 genes specifically that increase the risk for breast cancer. So things like PALB2, CHEK2, RAD51C and D. So there's a number of these that contribute. They have different risks. So for example, somebody with a CHEK2 mutation has a higher risk for breast cancer than the general population, but not as high as BRCA1. So each gene kind of has its own particular risks and types of cancer that it's associated with. There's not necessarily an easy way to correlate, at least as of today. This will probably change in the future. We can't necessarily say, okay, somebody who has an ATM-related breast cancer is more likely to have a better or worse prognosis. At this point, a lot of that is more dependent on stage that it was detected, response to various treatments. Sometimes genetic testing on the cancer itself can help provide information about what medications may or may not work as well. Sometimes, like with Janice, something like triple negative breast cancer, there's some association where those are more likely to be BRCA1 related. So sometimes there are associations with particular types of breast cancer, but we haven't quite figured out yet if there's a correlation to specific prognosis aside from the stages that it was detected.
Okay, and then we have Katie asked, do you recommend testing again if you tested over 9 years ago?
Definitely. Even without a copy of your results to look at, I know that we can test for more now than we could 9 years ago. So absolutely.
And then I have one more question. You talked earlier about PARP inhibitors and those being able to do some DNA repair. Is that correct?
Yeah, so the way that PARP inhibitors work, so BRCA1 and 2 is a pathway of DNA repair, right? Our bodies have all these ways of repairing DNA because if our cell is making way too many mistakes, it just can't function and it dies off. So we have all these ways that our body repairs DNA, and the BRCA1 and 2 pathway is one of them. The PARP pathway is another. So the reason why PARP inhibitors work for BRCA-associated cancers is because if your BRCA pathway is already knocked out, you're losing a lot of this repair. So if you also take out its backup repair, which is the PARP pathway, then the cell basically just has no repair and it just can't function and those cells die. But if somebody has an intact BRCA pathway, then knocking out the PARP doesn't help because you still have this other method of repair. So that's why it's so specific to BRCA positive cancers. Does that make sense?
Yes. So I guess my next question is there technology out there now that allows like a mutation in your gene to be repaired? And how far away are we from that if it's not available?
Not as far away as we might think. So there's a technology, you may have seen it out there, called Crispr.
Yes.
Which is basically a way of editing our DNA. And so we're not there yet with this being ethically available and commercially available, though in some research settings they are starting to use it. So for example, for sickle cell disease, they're starting to have some clinical trials where you can actually cut out the gene that says sickle and replace it with one that says make normal hemoglobin. And it's basically like cut and paste. We are not there yet in the mainstream, but I think one day we will. So by the time of, the next generation or their children after that, we may very well be able to say, you have a mutation in BRCA1. We're going to give you this injection. It's going to snip it out. It's going to replace it with a gene that works totally fine. That may be available one day. It's not there yet. And it's a challenge because if we have a BRCA mutation, that mutation is in every single cell of our bodies, right? Whereas for something like sickle cell disease, we can focus on the blood because we know that's where sickle causes the issues, is the shape of our red blood cells. So it's much more targeted than something like a cancer predisposition, where it's in all different organs that we have. So one day, yes, but as of today, not yet.
Okay.
Though some of the medications, so like immunotherapy, is basically trying to target our own immune system and trying to target particular things. So there's a lot of things in the pipeline and a lot of new and innovative ways to treat cancer, but we're not yet there on the copy paste.
Okay. And then so when you go back to PARP inhibitors, are those used in someone that maybe doesn't have a cancer diagnosis, but they do have the genetic mutation?
No.
No. Okay.
No, it's only designed to target those particular cells where BRCA is not working and leading to cancer.
Okay.
Though there are some, so for example, there's a study going on for a vaccine. So kind of using our immune system to lower our risks and prevent these types of cancer. But as of now, we wouldn't use PARP inhibitors to reduce our risk, though who knows, maybe one day.
Yeah. And then Mona asked, there's another question. How can we get resources about gene testing? And she'd love to learn more about this topic.
Yeah, so one option is we have a lot of information on our website, which is JScreen. Certainly, if you wanted to do genetic testing, I'd say either go meet with a local genetic counselor, or come through JScreen. Everybody who does genetic testing can meet with a genetic counselor, go through everything. And there's also a lot of great genetic testing or genetic information resources out there. So breastcancer.org has tons of information on their website about 1 million different breast cancer options, including genetic testing. Some of the NIH and cancer.gov websites have really good information. So, there's tons of other nonprofits like Twisted Pink out there who are there to educate and provide a lot of, things like printed materials, but also webinars, support groups, and things like that. So there's a lot of great information out there.
Okay. Any other questions?
I do have one more.
Yeah.
As we saw, and we see in the news every day, how people of color have not been involved in clinical trials.
Mm-hmm.
And we saw that with COVID because there was a difference in how we were treated, people of color versus Caucasian. How do we get these various groups connected to the clinical trials? Now, I know we've got that taboo out there that Black people in particular don't like clinical trials because of what happened in the past.
Mm-hmm.
But we've got to be able to dismiss that and reassure people. How do we get that started?
So I cannot agree with you more. And I think that there's, in this country, there are way too many inequities in healthcare and disparities that we see. And clinical trials and research are so important. I know one organization that is trying to encourage people. I'll put these in the chat, actually. There's two of them. One is called FORCE, which is Facing Our Risk for Cancer Empowered. And I know their founder has been very vocal about trying to encourage people to sign up for clinical trials, trying to reach providers to encourage enrollment in clinical trials. So that's definitely one good place to look. There's a sort of government-based one that's coming out, which is called Cancer Moonshot, where the government basically has had this big goal to reduce cancer by 50% by the year something. I can't remember off the top of my head. So there is a lot of funding being pushed towards that. And I know that, they want to improve these health disparities. We have actually partnered with a woman who was based out of Emory. She also had this question, and she started an organization which is called Golden Hoops, which is basically in memory of her mother who passed away from breast cancer. And she is specifically trying to target young Black women to try to educate them about genetic testing, and actually pay for them to have genetic testing, so that, because we know that women of color are being offered genetic testing at a lower rate. And so it's not even that they are tested less or not being or not accepting it, but they're not being offered it as much.
That's right. Absolutely.
So we've been sort of working with her of, how can we target more people who haven't otherwise heard of this information or haven't been offered it in the past, and try to, just educate them and encourage them. We're sort of more on the genetic testing and education side. It doesn't necessarily answer your question about clinical trials, but definitely look into FORCE. And then the other one is something called iCare, which is the Inherited Cancer Registry. They also they are more targeted on people who specifically carry genetic changes, but they are collecting tons and tons of data. They have a ton of different studies themselves or connecting people. So that's another great resource. Let me find.
And I'll tell you, there's a couple more, Janice. There's Tiger Lily Foundation is a great organization that works a lot to, break the disparities especially with clinical trials. And then Touch is another organization that I've worked with.
Yes, Touch is amazing.
And Ricky Farley is the executive director, and she, both of those organizations worked in conjunction with the Metastatic Breast Cancer Alliance to put on a conference at San Antonio, or a seminar at San Antonio called Black Women Speak. And that whole session was around this topic. And what I've learned through my work is that it's going to take champions from the Black community to really tell your story, and the ones that have gone through clinical trials and participated, and just go out into the community and tell your story and start talking about it. Because what I've learned is that Black women don't want a white woman to tell their story because you don't relate. And I can stand on a soapbox all day and talk about what I've been through with cancer, but it's different than what you've been through.
That's right. Absolutely. Yeah. I agree with that. Did you put it in the chat, Carolyn?
Yeah. Yeah.
Okay.
Yeah, sure did. And I'll email this out to everybody as well.
Right. All right. Well, thank you both. I appreciate you.
But we totally understand this is it's a challenge, and it's a big gap, and it needs to be addressed. And from our little piece of genetic testing in the world, I promise we're trying. But it's really going to take a world.
That's right.
A world of effort on many different fronts.
But it starts somewhere, right?
Exactly.
Yes, and I want to say one more thing. It's important to find a doctor that you're comfortable with, and that you're comfortable asking these questions to, and to advocate for yourself. Because if you leave a doctor's appointment not comfortable with something, you should find another doctor.
I agree, Carolyn. And that goes not just for cancer,
right?
It's for anything, because it's not just about cancer. But anyway, it's more easier said than done because you have to all this paperwork and transfer files, and it's just inconvenient for older people, not for me because I'm going to advocate for myself. But
Yeah.
unfortunately, it's not just young people that's sick.
Mhm.
Yeah.
Yeah, and I think people also don't realize it's okay and encouraged to seek a second opinion. And if you're not feeling like you're being heard and getting the information that you need, to go and find somebody who will listen and who will hear what you're asking.
Yes,
Yeah.
thank you.
Okay, so
So I put my email address in here. So if anybody does come up with any questions or has any questions about testing or anything like that. And then Caroline, I think you can send around the recording and the code.
yes, I'm going to do that. I'll download the recording and it'll be on our website, and I'll send it out to everybody that registered for the event today. Even if they weren't here, everybody will get a copy of the recording or a link to it. And then as well as the chat questions, and then all of the links to the different organizations as well. And you're welcome to call me if you have another question later on, and I'll get in touch with Emily and try to get an answer for you if you have any questions. Thank you all for being here today. And thank you,
Nice meeting
Emily,
everybody.
for your expertise.
Happy to help. And I'm here if there's anything I can do down the road.
Bye-bye.